Hello to all the doctors who are present here today. As dentists, we are aware that success of a root canal treatment depends on many factors. So some of them are within our control and some of them are beyond our control. One such important factor, or rather step in the root canal treatment, is working length determination. This is like the foundation for the whole procedure. So this is the topic for today. Endometrics, the key to a successful root canal treatment. I am Dr. Vidya Shenoy, practicing endodontist from Bangalore, Karnataka. So this is an overview of this presentation. First we will see what is endometrics, its importance, what happens if working length is overextended or short, a brief overview of anatomy of root apex. We'll then address the real question, that is, where should the root canal preparation terminate? Different methods of working length determination, electronic apex locators, its generations, how to use it clinically, its applications in special clinical scenarios such as open apex, retreatment cases and cardiovascular patients. Finally, an overview of CanalPro Apex Locator, which is a beautiful product from Coltene. Endometrics is the science of determining working length in endodontics. We know that working length is the distance from a coronal reference point to a point at which the canal preparation and obturation should terminate. So this factor is very critical in determining the prognosis of an endodontically treated tooth. While doing a root canal treatment, what we concentrate mainly on is to properly clean and shape the root canal system. Of course, this is important because we have to remove the microorganisms from the root canal system. But along with this, what we should also keep in mind is that we have to maintain the integrity of the periapical region. There should be no violation of the periapical region of the tooth. Why this is important, we'll discuss in the coming slides. Proper working length determination is important for two main reasons. One is to help the patient get rid of the pain. Second one is to ensure healing of the tooth. Pain is the most common reason why patients visit dentists, right? This pain is caused by infected pulpal tissue and microorganisms that are present in the root canal system. So we have to ensure that proper working length is determined so that we can remove the infected pulpal tissue and help the patient get rid of pain. How do we know when healing has occurred in the tooth? So clinically, when the patient is free of symptoms and is able to function normally without any discomfort with that particular tooth, we can say that the tooth has healed. It was found in a study that tooth with overextended obturation is 4 times more likely to fail than under-obturated canals. So what exactly happens if working length is overextended? As you can see from this IOPA that the apical constriction is perforated. So during instrumentation, when the apical constriction is perforated, the debris from the root canal system or the infected pulp tissue can go into the periapical region. Even the irrigants can get extruded into the periapical region. So all these things can trigger a massive inflammatory reaction which can cause flare-up, that is mid-treatment flare-up during a root canal treatment. The patient can experience severe pain because of this. Another thing that will happen because of the perforation of apical constriction is that the obturation that we do will eventually be overextended. So this can compromise the apical seal, which can in turn lead to apical leakage. So this is again another reason for post-treatment flare-up that we can see. Patient may present with pain or swelling because of the overextended obturation. Now, since the periapical region is violated, it takes time to heal. This ultimately lowers the success rate of endodontic treatment. Various studies have reported failure due to short obturation to be ranging from 18% to more than 34%. So what are the consequences of short working length? First and foremost, it leads to incomplete cleaning and shaping of the root canal system. Because of this, the infected pulpal debris along with the microorganisms remain in the root canal system. So this can cause the patient to have pain. Second thing is that short working length will lead to short obturation. Because of this, there is incomplete apical seal and apical leakage can occur, as I've explained in the previous slide. And again, these short working length can cause procedural errors during instrumentation. So because of this, there can be canal transportation or ledge formation or zipping or even root perforation can occur. So all these factors will cause failure of the root canal treatment. Additionally, because of the procedural errors that have occurred, the re-root canal treatment can become challenging. This is a diagram showing root apex of a tooth. So to fully appreciate the concept of working length, an understanding of the apical anatomy is required. There are three distinct aspects of root apex we must appreciate. First one is the anatomic apex or tooth apex. Second one is the apical foramen or major foramen. Third one is the apical constriction, also known as minor foramen. As you can see in this picture on the left hand side, the anatomic apex is marked. The apical foramen is marked in green. The apical foramen is not always present at the anatomic apex. Its location can vary for different teeth. Cutler in his study found that for younger age group, the distance from anatomic apex to the major foramen is an average of 0.48 millimeter. And for an older age group, it is 0.6 millimeter. So with age, this distance varies because of different processes such as resorption, cementum deposition, etc. You can see where the apical constriction is marked in this picture. So this apical constriction is the narrowest part of the root canal. It has the smallest diameter of blood supply, and the root canal preparation to this point will result in a small wound site and optimal healing. As you can see in this picture on the right hand side, a landmark called CDJ is marked. This is the cemento-dentinal junction. This is the point where the dentin ends and cementum begins. This point, usually it coincides with the minor constriction or the apical constriction, but it can vary in different teeth. So this is again an important landmark of the root apex. What do you observe from this IUPA? You can see that tooth number 47 has been obturated, and it is a fairly good obturation which is obturated till the apex, and it follows the root anatomy beautifully. So this indicates that good cleaning and shaping was done. So the dentist is happy seeing this radiograph, thinking that okay, it is looking good, I have obturated till the apex. But after a few days, the patient comes back saying pain is still present on that tooth and I'm not able to eat on that side. So what are our first thoughts in this situation? We'll be thinking, okay, I've done a good root canal treatment, but still the patient is having pain. Maybe there is a missed canal, maybe the cleaning was not sufficient and pulpal remnants are still present. But what we are forgetting here is, this is a two-dimensional image. The radiographic apex and the anatomic apex does not always coincide. So what obturation appears to be till the apex might be actually beyond and encroaching the periapical region, which might be the reason for the patient to have pain. You will be able to appreciate what I was talking about in the previous slide from this picture. From the picture on the left hand side, we can clearly see the location of the radiographic apex and anatomic apex varies. But we often forget this and we obturate till the radiographic apex. Because of this, the gutta percha ends up in the periapical region and it can have severe consequences in the patient. The second picture on the right hand side is a diagrammatic illustration of how the gutta percha is seen to be at the apex on an X-ray film, whereas in reality it is actually beyond the apex. we can see that it has caused severe bone loss in the periapical region. So now the real question is, where should the root canal preparation terminate? There are so many opinions regarding this, and we are usually taught that the obturation should be till the apex as seen on an IOPA. So this is a list of few cross-sectional studies, systematic review and meta-analysis. All their conclusions are the same, that is root filling which terminates within 2 mm of radiographic apex has the best outcome. So ideally the preparation should terminate at the apical constriction. This is at a distance of 0.5 mm from the apical foramen in younger patients and at a distance of 0.8 mm in case of the older age group. Why the apical constriction? Because at this point the wound site will be small and it can cause optimal healing. And beyond this point, there is a chance that the instruments and the obturating material can encroach the periapical region. We usually measure working length till the same point for all tooth, that is till the apical constriction, regardless of the status of the pulp. But status of pulp tissue is an important factor that we have to take into consideration while measuring working length. In vital tooth, that is tooth with irreversible pulpitis, working length is established as close to the apical constriction as possible. This is done so that all the procedures are within the root canal. Second thing is it creates a small wound site which will give optimal healing. Another thing is it will lead to the formation of cementum instead of fibrous tissue, which is seen in case of chronic inflammation. In case of non-vital tooth with pulpal necrosis or presence of periapical radiolucency, working length is established as close to the canal exit or slightly short of the apical foramen. This is done to clean the entire length of the canal so that we remove as much bacteria as possible and all the substrates that can encourage bacterial regrowth are removed. What we should also keep in mind in such cases is that there could be apical resorption present. It may or may not be seen on a radiograph, but usually resorption is present in case of tooth with periapical radiolucency. So in such cases, cleaning and shaping of the canal is done to the entire length of the root, and then further procedure has to be done by retreating into the canal. There is this beautiful article regarding apical termination of root canal procedures by Dr. James L. Gutman. You can go through it. It answers so many of our complex questions regarding root canal procedures. So this is the title of the article. Coming to the methods of working length determination, there are radiographic methods and non-radiographic methods. And under each method, there are so many techniques that are listed. Of course, traditionally the tactile sensation was used to locate the root apex, and this was done based on the clinician's practice and experience. What is popularly used clinically is the INGLE'S radiographic method, and recently the electronic apex locators have also been gaining popularity. Since INGLE'S radiographic method is most commonly used one clinically, we'll discuss this technique. First, a diagnostic radiograph of the tooth to be treated is made. Then, measure the distance from a stable occlusal reference point till the radiographic apex using a scale on an IOPA. After this, subtract at least 1 mm from this length. This is done for two reasons. One is the minor constriction is present short of the radiographic apex. Second reason is to compensate for radiographic image distortion. After this, the measurement is transferred onto an endodontic file, which is then placed inside the root canal, and a working length IOPA is taken. Once you take the working length IOPA, what you should do is you should measure the distance from the tip of the file to the radiographic apex. The tip of the file should lie within 0.5 to 1 mm from the radiographic apex. If the file position is short or beyond this measurement, readjust the file and then take the IOPA again to confirm the working length. we'll see what are the limitations of traditional working length determination techniques. Working length assessment using tactile sensation becomes unreliable because of anatomical variations in apical constriction, such as its location, size, or tooth type. For example, if the canal is sclerosed or the constriction has been destroyed because of inflammatory apical resorption, locating the apical constriction using this technique becomes difficult. One of the drawbacks of radiographic method is when the apical foramen exits from the side of the root or in a buccal or lingual direction, it becomes difficult to view on the radiograph. Second thing is, if there is dense bone around the tooth or anatomical structures which can make the visualization of root canal files impossible, working length determination is difficult again. In the first picture, you can see how hypercementosis is making the location of apical constriction difficult. And in the second picture, the maxillary sinus is obscuring the view of the root apex. The main problem of this radiographic method is that it is technique sensitive. So because of this technique sensitivity, it is prone to many errors such as image distortion, light radiograph or dark radiograph or overlapping image, etc. So coming to electronic apex locators, this mode of working length determination is gaining a lot of popularity among clinicians these days. This technique has to be used as an adjunct to radiography. At least one preoperative radiograph must be taken so that we get an idea of how the anatomy of the root looks like. And this is the only mode which can accurately locate the apical constriction. There is no other technique for working length determination that will give us the accurate location of apical constriction. It is also known as electronic root canal length measurement device. We'll take a brief look at the timeline of how the electronic apex locators came into existence. In 1918, Custer was the first person to investigate electronic method for root canal length determination. This idea was revisited by Suzuki in 1942, who investigated the flow of direct current through the teeth of dogs. So later in 1962, Sunada took these principles and constructed a simple device that used direct current to measure the canal length. He found electrical resistance between periodontium and oral mucous membrane. So in 1969, the first generation electronic apex locators was introduced. This was followed by the introduction of various generations of electronic apex locators consequently. We'll discuss about these individual generations in the coming slides. An electronic apex locator has four main parts. That is electronic apex locator device, which has the control features and the display panel. Second one is the measuring wire, which connects the device to lip clip and file holder. On the device, there is an on and off button, a button to adjust the sound, and a menu button. The display panel will show the location of the file as it moves through the canal. The lip hook or the clip is placed at the corner of the patient's mouth while measuring the working length to complete the circuit. And the file holder, as the name suggests, is to hold the file in position as you measure the working length. So what are the uses of these electronic apex locators? It is useful in conditions where apical portion of the canal is not visible because of anatomical obstructions such as impacted teeth, zygomatic arch, tori, or excessive bone density, overlapping roots, or presence of shallow palatal vault. So in such cases, the radiographs are not of much use. So these electronic apex locators can be used for determining working length. It is useful in patients who cannot tolerate X-ray film because of gag reflex. In case of pregnant patients, to reduce radiation exposure. In case of children who may not tolerate taking radiographs, and in patients who are heavily sedated. The apex locators are very useful in detecting site of root perforation, such as in case of external or internal resorption where the root has perforated or perforation caused during post preparation. It also helps to detect horizontal and vertical root fracture. How it helps in all these diagnoses we will discuss in the further slides. The advantages of electronic apex locators, like I mentioned earlier, it is the only method of working length determination which helps to locate the apical constriction accurately. And all the uses of electronic apex locators that I mentioned in the previous slides are its advantages. Another thing is that certain apex locators, they come in combination with pulp tester. So it can be used to test pulp vitality as well. The disadvantages of apex locators include it can provide inaccurate readings in certain conditions clinically, that is presence of pulpal tissue in the canal, if the canal is too dry or too wet, if we use a narrow file to locate the working length, if there is blockage in the canal due to some ledge or buildup of debris, and if the circuit is incomplete as well, it can give inaccurate readings. We'll see the clinical steps that are involved in using apex locators. First and foremost, the most important thing is making a preoperative radiograph. This will give us information about the anatomy of the root. So, for example, if any curvature is present or resorption is present because of the periapical radiolucency. So for that, this radiograph is very important. After that, isolate the tooth using rubber dam. Then open the axis. Once you open the axis and the canals are located, make sure that the pulp chamber is not flooded with irrigants and the root canal system is not flooded with irrigants, because if there is any fluid present in the pulp chamber, it can cause electrical shunting. So for this, you can use paper points to dry the root canal, and to dry the pulp chamber you can use the 3-way syringe. Okay. Then make sure that there is a stable reference point in the axis. So if there is any unsupported tooth structure present, just flatten it, because this reference point should be reproducible in case you recall the patient for the next appointment. Another thing we have to keep in mind is we have to select a snugly fitting file. That is, a larger file which contacts the walls of the root canal should be selected. Then before using the apex locator, make sure all the parts are well connected. That is, the measuring wire is connected to the device and the lip clip and the file holder are properly attached to the measuring wire. One main important thing that you have to keep in mind before using this device is that the battery should be fully charged. So some apex locators, even if the charge is down by 1 bar, it will give inaccurate readings. So once this setup is ready, place the lip clip at the corner of the mouth of the patient, attach the file onto the file holder and place it in the canal. On the display of the apex locator device, you will see readings like this, like zeros, 0.5, 1, 1.52. So these are not indicators of the distance or the measurement of the file from the apex of the root. These are just readings of the apex locators which will give you idea of the position of the file. Once the file is placed in the canal, advance it till you get the apex or 0 reading. This is the most accurate point till which you should measure the working length on an apex locator, because at this point the file will be contacting the periodontal ligament. So once you get this 0 reading, remove the file from the canal and measure the length. So from that length, reduce 0.5 mm. This reduction we should do to make sure that the file is within the root canal system but still close to the PDL, and all the instrumentation procedure is within the confines of the root canal system. Another important thing is that we have to recheck the working length after shaping the coronal thirds. This is because once you shape the coronal third, if there is any curvature present there, that will be reduced. So this may reduce the initial working length of the tooth. So we need to recheck the working length. These are few tips to measure working length accurately using electronic apex locators. Firstly, when the access cavity is made, make sure that all the metallic restorations are removed. So this we have to do in order to prevent any short circuit from happening. Next, extirpate the pulp. After that, make sure that there is no fluid in the pulp chamber. So for this, you can use the 3-way syringe and gently dry the pulp chamber. Then use the largest endodontic file possible to measure the working length. So what I mean to say from this is, use a file which will contact all the walls of the root canal. So that will give the best result using Apex locators. Then make sure the root canals are dry. So for this, you can use paper points. If any irrigants were used, use paper point, dry the canal and then measure the working length using Apex locator. Another thing what you have to keep in mind is, if there is any inflammatory exudate or pus present in the canal, this can interfere with the readings of the Apex locator. So in such a situation, what you can do is give a calcium hydroxide dressing, recall the patient and measure the working length in the subsequent appointment using Apex locator. Isolating a tooth using rubber dam while doing root canal treatment is very important. So what are its advantages? The main advantage is to prevent saliva from pooling in the pulp chamber. So this has two uses. Firstly, it will prevent any contamination of the pulp chamber or the root canal system. Second thing, if the saliva comes in contact with the file holder of the electronic Apex locator, it can cause short circuit. So this is prevented using rubber dam. While using Apex locator, what we have to keep in mind is that the file clip should not contact the oral mucosa or the tongue. If it does contact, it can give negative or incorrect readings. So rubber dam will help us to prevent this from happening. And like I discussed earlier, the lip clip or the file holder should not come in contact with any metallic restoration, since it can cause short circuit. Also, if the lip clip and the file holder come in contact with each other also, it can cause short circuit and the patient can experience pain. So all these things are avoided from happening using a rubber dam. What do we do in cases where the tooth is grossly decayed and there is insufficient crown structure? So in such cases, do a pre-endodontic build-up. Again, this is done to prevent any saliva from pooling into the pulp chamber, and it will help us in isolating using rubber dam. What we have to keep in mind while using an Apex locator is that the battery should be fully charged. This is very important, because even a slight reduction in the charge can give us incorrect reading, or we would have noticed that there are fluctuations in reading. So one of the reasons for that is a low battery. Another reason for fluctuations in reading of the Apex locator is if the file holder is rusted. So in such a case, replace the file holder and take the reading. So how do these electronic Apex locators work? The electronic Apex locators function by using the human body to complete an electrical circuit. So on one side, it is attached to the oral mucosa through the lip clip, whereas on the other side, it is attached to the file. So when we place the file inside the root canal and advance apically till the tip of the file touches the periodontal ligament at the apex, the electrical circuit is completed. Once this circuit is completed, the electrical resistance decreases markedly and current suddenly begins to flow. So depending upon the device, this sudden current flow is signaled by a beep or a buzzer, or maybe a flashlight or pointer, whatever is the function of that Apex locator, it will display. The electrical characteristics of the tooth structure are measured and exact position of the instrument in the tooth is determined. This is a classification of electronic Apex locators given by MacDonald. He classified electronic Apex locators based on the type of current involved, that is direct current and alternating current. Under the alternating current, there are three types of apex locators, that is resistance type, impedance type and frequency type. The examples for each type is given in the table. This is another classification of electronic apex locators based on generations. The first generation is resistance based, second is impedance based, third is frequency based, fourth is ratio type, fifth is dual frequency ratio type, and sixth is adaptive type. I'll discuss each generation individually in the coming slides. The first generation apex locators was based on measurement of electrical resistance. They measured opposition or resistance to the flow of direct current. Initially, a high current of 150 Hz sine wave was used in these apex locators, which caused the patient to have severe pain. So, a few modifications were made and a small current of 5 microampere was later used. Still, the use of a direct current caused electric shock sensation to be felt by the patient. Also, these apex locators were unreliable when compared with radiographs. So, because of all these drawbacks, the use of first generation apex locators were discontinued. Second generation apex locators were based on measurement of electrical impedance. Impedance is the measurement of opposition to alternating current. So these apex locators were based on the principle that there is electrical impedance across the walls of the root canal. This impedance was greater apically than coronally. And at the cemento-dentinal junction, it dropped dramatically. So this property was used to measure working length using these apex locators. There were many variations in design seen in this generation. Few apex locators had to be calibrated at the periodontal pocket of each tooth. Then there were coated gingival frequency measuring probes. Another model had electrode connected to the dental chair. In spite of lot of advancement in this generation, they gave inaccurate readings in both dry canals and in the presence of electrolytes. So these were discontinued. Third generation apex locators used two frequencies to measure impedance in order to determine working length. How it worked is, two different frequencies of 400 Hz and 8 kHz were used to simultaneously measure the impedance in the canal. After this, a value known as quotient value was obtained by dividing impedance at 8 kHz by impedance at 400 Hz. When the quotient value obtained was 0.67, it was considered to be the location of apical constriction. So compared to previous generation of apex locators, this was found to be better in terms of accuracy and reliability. Root ZX is an example of third generation apex locators. Fourth generation apex locators use multiple frequencies to measure impedance. In the third generation, we had seen that a quotient value is obtained from the impedance value that was measured at different frequencies, which was then used to assess the working length. In this generation, resistance and capacitance is measured separately instead of measuring the impedance directly, and then it is compared with the database to measure the working length. This technology presumably leads to less sampling error and more constant readings. So far, this generation of apex locator is the best in the category owing to their high accuracy and reliability. CanalPro Apex Locator from Coltene is an example of fourth generation apex locator. The fifth generation apex locators was developed based on comparison of data taken from the electrical characteristics of the canal and some additional mathematical processing. They are supposed to perform extremely well in the presence of blood and exudate, but in dry canals they experience considerable problems. So it requires some additional liquids or irrigants to be inserted in the canal. The sixth generation of Apex Locators eliminates the necessity of drying or moistening the canal. So it achieves high degree of precision in the presence of blood or in the presence of irrigants such as sodium hypochlorite, or even while manipulating in dry canals. You can see here that the symbol of a moist canal is displayed, which shows that the device has measured the moisture in the canal and has duly adapted to measuring within the liquid. We will now discuss the use of Apex Locators in some special clinical scenarios. Measurement of working length using Apex Locator in teeth with open apex. Halsman from his study concluded that Apex Locators gave incorrect results in teeth with open apex. In another study, it was found that width of apical foramen influenced the accuracy of endodontic measurements. So many authors evaluated this. They found that diameter of apical foramen corresponding to file size 60, 80 and 90. Beyond these diameters, the apex locator measurements became unreliable. So in cases with open apex, it is better to use radiographic method for working length determination. Electronic length measurement in endodontic retreatment. During endodontic retreatment, usually more number of radiographs are required compared to the primary root canal cases. So, using apex locators can help us to reduce the number of radiographs that are required and reduce the radiation exposure of patients. Many studies have evaluated the accuracy of apex locators in retreatment cases, and they have found the accuracy to be ranging from 83 to 93%. So overall, the apex locators show lower accuracy in retreatment cases compared to the primary root canal cases. This is because the presence of residual obturating material gives inaccurate readings of apex locator, and apex locator can sometimes cause overestimation of working length in retreatment cases. This is because of the apical extrusion of debris or the obturating material, which can cause poor conductivity. Again, the presence of solvents which we have used for guttapacha removal can adversely affect the accuracy of apex locators. This is again because of the electrical conductivity of the solvent. So overall, we can say that we can use apex locators in retreatment cases as an adjunct to radiography. But what we should keep in mind is the presence of obturating material residues or the solvents can affect its accuracy. So these are few clinical tips to prevent overestimation of working length using apex locators in retreatment cases. Once we measure the working length till the 0 mark or the apex mark, subtract 1 mm from this working length and then do the cleaning and shaping. Again, once the obturating material is removed completely from the root canal, measure the working length using apex locator and then continue with the preparation. Electronic length measurements in cardiovascular patients with cardiac pacemakers. The electronic apex locators produce electric and magnetic field around the head with distance ranging from 25.5 to 30.5 cm from the heart. The newer generation cardiac pacemakers are considered to be impervious to most sorts of interferences. This is because they are encapsulated in components of stainless steel or titanium. Along with this, these new devices have bipolar LEDs and capacitors that will effectively filter out electromagnetic interferences. So direct contact between the apex locator and pacemaker is not possible in practice. Along with this, the patient's body bulk, that is the skin, fat, muscle, bone, can resist conduction of electromagnetic currents and act as a second capsule. In a systematic review, it was concluded that electrical appliances have to be placed at least 10 to 20 cm away from an implantable cardioverter defibrillator. But for patient safety and for us to be on the safer side, it is better to take the cardiologist's consent and then use apex locators in patients with cardiac pacemakers. Coltene has come up with a beautiful product that is CanalPro Apex Locator for working length determination. It is a 4th generation Apex Locator. It uses 2 alternating frequencies for measuring working length. So it eliminates noise and the need for signal filtering. This Apex Locator uses signal intensity to calculate the file tip position, which makes the measurement immune to any electromagnetic interference. This Apex Locator has an additional feature, that is the virtual apex function. So this feature will allow the clinician to mark a predetermined distance from the apex before measuring the working length. So it is useful in clinical situations where there is inflammatory apical resorption. So where you can determine till where you want to prepare the canal and you can mark that point on the device. So once this feature is enabled, a clear visual and audio notification is received once the file tip has reached the selected mark. This Apex Locator has a 3D interface based on a high resolution color graphic display. It shows the movement of the file inside the canal from the beginning of the measurement to the end and provides uninterrupted feedback to the dentist. These are images of display panel of CanalPro Apex Locator. As you can see, there are 2 images on the display panel. That is, one shows the file tracking, that is the position of the file as it moves from the coronal to the apical third. So this is advantageous in case of any canal blockage. If it is present, we can know where exactly the file is stuck. In the second image, you can see that the apical zone is shown enlarged. So as the file approaches the apical third, the position of the file is shown on this enlarged picture and we can determine the location of the file. In case of over-instrumentation, a bleeding symbol appears on the display, which gives us the indication that file is beyond the apical foramen. CanalPro Apex Locator Compact is another product from Coltene for working length measurement, which is a compact version of the CanalPro Apex Locator. Similar to the CanalPro Apex Locator, the display panel has 2 images. One image shows the movement of the file in the tooth, whereas there is an enlarged image which shows the movement of the file towards the apex. And as the file approaches the apical constriction or the 00 point, the mark is shown as red. And if the file is over-instrumented, the bleeding sign appears, similar to the CanalPro Apex Locator. So this study compared the accuracy of 2 different Apex Locators, that is 5th generation Apex Locator and CanalPro Apex Locator, which was a 4th generation Apex Locator, in determining working length in root canals. So CanalPro Apex Locator was found to be highly accurate compared to the 5th generation Apex Locator. The CanalPro Apex Locator measured working length very similar to the actual length of the tooth. So this is another study evaluating the accuracy of 3 electronic apex locators in curved canals of mandibular molars. So in this, a 3rd generation apex locator was compared with a CanalPro Apex Locator and another 4th generation apex locator. As you can see from this graph, that CanalPro Apex Locator was most accurate compared to the other 2 apex locators. So this study evaluated the accuracy of 3 electronic apex locators in different simulated clinical conditions, such as presence of sodium hypochlorite in the canal, teeth with open apex, presence of pulp tissue and blood in the canal. So as you can see from this graph, the CanalPro Apex Locator gave the best result in case of all the simulated clinical conditions. In this study, a 3rd generation Apex Locator and CanalPro Apex Locator were evaluated for detection of fracture in the coronal, middle and apical third of tooth. CanalPro Apex Locator detected fracture better than the 3rd generation Apex Locator at all the portions of the tooth. So how do the Apex Locator detect fracture or perforation? The electronic apex locator marks the first zone which communicates with periodontal ligament as the apex or the 00 point. So in case of fracture or perforation, the apex or the 00 mark will be obtained earlier than the expected working length. So this way apex locators help in diagnosing fracture or perforation. CanalPro Apex Locator was compared with other apex locators to evaluate debris extruded during instrumentation following working length determination using these apex locators. It was found that when cleaning and shaping was done following working length determination using CanalPro Apex Locator, less debris was extruded compared to the 5th generation apex locator and radiographic method of working length determination. In order to improve the success rate of an endodontic treatment, it is very important that we determine the working length accurately. So for this, we should have knowledge regarding the apical anatomy of the root and use diagnostic radiographs so that we can analyze the anatomy of the root and the periapical region. We should also take the pulpal status into consideration for working length determination. Finally, the apex locators should be used correctly following all the proper clinical steps so that we can measure the working length accurately. I thank Coltene for giving me this wonderful opportunity, and I thank all the doctors for being a part of this presentation.